session. Dr. Anusha is there. You are the first one. Okay, some few people have left, so we have to stick to the timings because a lot of topics to be shared. So I think we'll start off. Dr. Anshu, yeah, you can start off with your topic first. So he'll be talking on clinical spectrum of tuberculosis uveitis in a tertiary eye hospital.
Tuberculosis is one of the leading infectious cause of deaths. So, worldwide prevalence of isolated ocular tuberculosis varies significantly from 0.2%
The
to
slides are not working, please. Check the slides. Yeah.
ocular tuberculosis presents significant challenges. It is one of the most common cause of granulomatous uveitis in our country, and tuberculosis uveitis is a form of extrapulmonary tuberculosis. To evaluate, aim of study is to evaluate the prevalence and pattern of tuberculosis uveitis in a tertiary care hospital. Material methods retrospective interventional study was done from April 22 to 23 May at Rio RIMS. History of TB contact, demographic profile, and ocular manifestation of patient were noted. Patient underwent detailed ocular system examination, BCVA slit lamp biomicroscopy, IO fundus exam, FFA-B scan, and OCT. Routine lab workup was done, sputum culture, FNAC if needed, and in cases of diagnostic dilemma, intraocular fluid evaluation for PCR or RT-PCR, quintiferon, TB gold, interferon, gamma release assay, ancillary ophthalmic investigations were. Inclusion criteria were all patients having uveitis visited a OPD above 12 years of age, and exclusion criteria uveitis following any intraocular surgery, endophthalmitis, uveitis following any intraocular trauma, secondary to any malignancy. All patients having uveitis who fulfill inclusion criteria were included in the study. 40 eyes of 25 patients were analyzed. Age range was 60 to 62 years. Mean age of presentation being 31 plus minus 5 years. Bilateral in 17 patients, unilateral in 8 patients. And 8 patients had prior history of systemic tuberculosis, while 17 had no prior history of tuberculosis. All the 25 patients identifying having uveitis were recommended for treatment. And out of these, 17 patients completed therapy and complied, and rest were lost to follow-up. Most of the patients complained of visual loss, pain and floaters, redness, and clinical presentations included choroidal granuloma 46.5, intermediate uveitis 20%, granulomatous anterior uveitis 11.5%, pan uveitis, multifocal choroiditis, 3 eyes, serpiginous in 1 eye 3.5%. This is the result in graphic representation. And the study published in 2015 by Das et al. Among posterior uveitis, Biswas et al. Study posterior uveitis cases comprised of 25% of study in population. Dogram et al. Study concluded among specific etiologies. Most common presentation of tuberculosis uveitis is of disseminated choroiditis and choroidal tubercles may be one of the earliest signs. Ocular tuberculosis presents a complex clinical problem due to wide spectrum presentation, posterior synechia, retinal vasculitis with or without choroiditis, and serpiginous like choroiditis in patients with latent or manifest tuberculosis are suggestive of tubercular cause of uveitis. Tubercular retinal vasculitis typically an obliterative periphlebitis affecting retina and multiple quadrants. Conclusion was most patients with ocular involvement have no history of pulmonary or other systemic form making definitive diagnosis. Ocular tuberculosis is a mysterious condition with a wide range of clinical presentation and should be considered in differential diagnosis of any type of intraocular inflammations. These are references. Thank you. So I could not attach the photographs or anyone.
That's what we wanted to see, that you have written 46% you diagnosed it as a granuloma.
Yes, sir.
So were you able to find so many, because it's multifocal choroiditis or intermediate uveitis you usually get, so 46% of your patient had granuloma. What was your diagnostic criteria? The Montux only, or beside
no,
that?
or other investigations are like we got this chest X-ray and if needed HRCT wave.
But you said you have extra pulmonary TB in most of the cases, right?
Yeah.
Or it was a pulmonary TB?
Yes, sir.
All right. Thank you.
Thank you.
I'd like to call up the next presenter, Dr. Shirisha Doga. She'll be presenting on VKH managed by peribulbous steroids. Okay, interesting. Over to you.
Today my presentation is on what Koyanagi-Harada disease managed by peribulbar steroid report of 2 cases. VKH is an idiopathic multisystem autoimmune disorder with a genetic predisposition with ocular, auditory, integumentary and neurologic involvement. It is a bilateral panuveitis affecting the young individuals. VKH has 3 categories: complete, incomplete and probable has isolated ocular manifestations. The key to successful therapy is early and aggressive systemic treatment. We present here 2 cases which are managed by initial intensive systemic corticosteroids followed by peribulbar depot steroids and systemic immunosuppressives. Case 1 is a 32-year-old female patient with history of diminution of vision, headache and tinnitus, visual acuity of 1/16, 6/60. On fundus, there were multiple serous detachments, multiple pinpoint leaks and late pooling on FFA, and increased choroidal and retinal thickness with multiple serous detachments on OCT. Case 2 is a 52-year-old female with diminution of vision in both eyes, visual acuity of 2/60 and 1/60, and with a similar presentation as case 1. CBP, ESR and serological tests for viral pathologies were all negative. Initially, high steroid pulse therapy, that is intravenous methylprednisolone 1 gram for 3 days was given, followed by the posterior subtenon triamcinolone acetonide PST 40 milligrams in both eyes. After that, they were started on oral azathioprine 50 mg BD for 6 months. On follow-up, the patient was feeling good with improved vision, but initially one patient had high IOP and it was managed by the topical dorzolamide timolol maleate. At 1 year follow-up, the visual acuity was 6/6 with normal OCT and a sunset glow fundus. In case 2, at 15 months follow-up, the vision was 6/6, normal OCT and normal IOP. The diagnosis of VKH is essentially clinical and it is supported by angiographic and OCT features which are mentioned above. To control this active inflammation, the initial episodes need to be treated aggressively with steroids and they remain the mainstay of treatment. That is the IV methylprednisolone for 3 days followed by oral prednisolone. However, they are associated with side effects like hypertension, hyperglycemia and patient compliance is also very poor. Hence, poor compliance, early and abrupt withdrawals are responsible for most of the recurrences. To overcome these problems, we gave IVMP for 3 days followed by PST and systemic immunomodulator drug which is the azathioprine. Hence, to overcome all these problems, instead of to overcome mainly the poor compliance of the patient, we gave the depot preparation of the steroid. Others have reported a case series of 32 patients which are successfully managed by PST and oral azathioprine. I conclude by saying that initial aggressive treatment with IV methylprednisolone followed by peribulbar long-acting corticosteroids and immunosuppressives, avoiding the side effects of systemic steroids, gives a good visual outcome without any recurrences.
Good presentation, but we are still not able to make out whether it was the PST which worked out or it was IVMP in the starting. So there is hardly any gap. After 3 days, you have already injected the PST.
No, sir. Initially, IV methylprednisolone was given as soon as the patient was diagnosed. And after that, within a gap of 1 week, we have given the first dose, and after 1 week, we have given the dose of PST for the other eye.
So you gave it in one eye, then you waited for a week, and then you gave it in the other eye. And azathioprine you started simultaneously?
Yes, sir. Azathioprine was started simultaneously.
So we don't have a clear-cut guidelines where you are, is it the PST or is it the immunosuppressants which are acting? So it would have been good if you have started with PST, then you would have labeled it as that, yes, the PST itself is working that nicely.
Since the mainstay of treatment is steroids, so we have given that depot preposition so that the systemic side effects can be avoided. And to maintain that, we have given this.
All right. So thank you, Dr. Shirsha. Moving on to our next speaker, Dr. Aishwarya. She'll be talking on treatment of RAM with diode laser.
Good morning, everyone. Today I'll be talking about a case report on the treatment of retinal artery macroaneurysm with diode laser. Retinal artery macroaneurysm RAMs are rare acquired dilatations of retinal arterioles, usually within the first 3 branches, and it is prevalent in the elderly with systemic hypertension, atherosclerosis, hyperlipidemia, and cardiovascular diseases. Majority undergo spontaneous involution, but the major cause of the vision loss in these patients is chronic macular edema, and subretinal hemorrhages. The treatment of RAMS itself is controversial. Intravitreal anti-VEGFs and retinal lasers can either be used in combination or in isolation in the management of these RAMS. My case is regarding a 65-year-old male patient with hypertension presented to us with a history of diminution of vision in the left eye for more than a month. The right eye was normal. The left eye has a visual acuity of counting fingers 3 meters with a normal anterior segment, and on the fundus examination we found out that there was an oval pink lesion in line with the inferotemporal artery below the optic disc, surrounded by subretinal blood and retinal edema and exudates involving and extending up to the fovea. On fluorescent angiography, there was a homogeneous and almost total filling of an oval shaped macroaneurysm surrounded by a block fluorescence with mild diffuse leakage, and we treated it using a diode pump frequency double laser of subthreshold parameters, and we applied around 10 spots surrounding the lesion in single row. At 1 month follow-up, the best corrected visual acuity was 6/60 with decrease in the exudation and edema and shrinking of the RAM. At 2 months follow-up, the visual acuity was 6/24 with a decrease in the subretinal fluid on OCT. At 5 months, the vision was around 6/12 with a very healthy looking and stable macula. At a 4-year follow-up, the visual acuity was 6/12 with a healthy stable macula. So the best approach to the treatment of RAM is still a matter of debate. But the spontaneous involution can occur in some patients, but long-standing exudative macular edema may lead to progressive photoreceptor cell loss with a deterioration in the visual function. Anti-VEGF have shown promise in improving the visual acuity, but previous reports have shown that there was a continued leakage into the macula. Conventional threshold laser treatment may cause arterial occlusion, scarring of the retina, and subretinal fibrosis. So the use of the subretinal laser treatment is an alternative approach with an advantage of reduced complication rate. I conclude by saying that our results emerging in our work where the photocoagulation is definitively the effective treatment of RAM, and subthreshold laser may reduce the vascular permeability, increasing the fluid reabsorption and promoting vascular repair. So it offers promising results in the treatment of the symptomatic RAM without causing any complications, and a multi-center randomized clinical trial is warranted to study the effect of this treatment modality on a larger scale if the appropriate settings are to be employed. Thank you.
Which was the laser you have used? Subthreshold laser.
Yes, subthreshold.
What were the settings you kept? Is it the different from the diode laser, double frequency diode laser?
We applied the settings were as shown on the screen were 200 microns and 200 millivolts in power.
Is it the green laser which you used? Because APA doesn't have a special subthreshold laser.
Yeah.
And did you do it in the very first sitting, or did you wait for a week or so before starting the treatment?
We did it in the first sitting.
Okay. And what do you think is the natural course of RAM?
It will if you have basically it is a dilatations, and if there are if it bursts out, it causes hemorrhages and exudates and retinal edema. So that is what we are trying to control it by giving a laser treatment, because chronic macular edema is very
self-resolution occurs in cases of RAM
if
in many of cases.
Some cases have been reporting that there is macular
Yeah,
edema.
there are always
That's
the
a promise.
cases. Chalo, good. Thank you so much. Next, I would like to call up Dr. Swati. She'll be talking on hyperbaric oxygen therapy for high altitude retinopathy. Can you have the slides, please? Okay. Meanwhile, can we have the next speaker? Dr. Ananya. Yeah, she's here. So she'll be talking on synergistic retinal pathologies, diabetic retinopathy, and covert impact of MDMA-induced hypertension.
Good morning, everyone. I shall be talking about synergistic retinal pathologies, diabetic retinopathy, and covert effect of MDMA-induced hypertension. MDMA, as we know, is ecstasy or molly, is a recreational drug consumed at rave parties. It is a serotonergic agent with neurotoxic potentials. The precise mechanism on the retina remains unclear. So a study was done to investigate the effects of MDMA on retina of mice. An increased expression of MMPs and tight junction protein decreased expression was noted, thus damaging the endothelial surface of the blood-retinal barrier. MDMA is also known to elevate noradrenaline levels, provoking hypertension, tachycardia, and vasoconstriction. In diabetes, we know hyperglycemia leads to activation of alternative pathways of glucose metabolism, thus leading to vascular endothelial dysfunction and ultimately leading to retinal ischemia. So, in our case, a 38-year-old male hailing from an urban slum presented to us with sudden diminution of vision in the right eye since 20 days and a black shadow in the left eye since 20 days. He is a known case of type 1 diabetic on insulin since 10 years and gives a history of consumption of MDMA 1 day prior to the symptoms. His systematic examination showed BP on slightly higher side on an otherwise normotensive patient and RBS was 200. His visual examination showed the right eye to be at 618 and N18 near, and left eye 69 and 8 near. Other examinations were normal. Pupils showed a sluggish response. On the fundus examination, there was vitreous hemorrhage in both the eyes, PDR in the right eye, when most importantly, we had optic disc edema in both eye with extensive cotton wool spots, flame-shaped hemorrhage, and hard exudates. As an immediate intervention, we advised PRP and strict systemic control. The patient did not follow through with this and reviewed on his own after 7 days. The visual acuity in the right eye has slightly decreased and pupillary response remained the same. But on dilated funduscopy, we noticed though vitreous hemorrhage had increased, there was a resolving optic disc edema with resolving cotton wool spots, flame-shaped hemorrhage, and hard exudates. If this case is analyzed, presence of diabetes in this patient makes the retinal blood vessels susceptible to the changes in the elevated blood pressure. So it's a possible mechanism for the hemorrhages. Therefore, ecstasy is an indirect factor accelerating the vascular pathology. Again, accelerated hypertension secondary to MDMA probably also explains the optic disc edema of the young male. And the flame-shaped hemorrhages and lack of vitreous cells support this diagnosis. Conclusion, this case shows an acute increase in hypertension following consumption of MDMA, precipitating the pre-existing retinopathy. Thank you. These are my references.
Did you measure the BP?
Yes, two times, 140 by 90. The patient keeps measuring his own BP as suggested, so he says that this is the highest he has ever gone.
But that doesn't conclude that the drug had led to that. That's kind of a normal BP. The age was how much?
38.
Slightly on the higher side, but he's a diabetic then, right?
Yes.
And how was the diabetic status, the HbA1c and all?
7.2.
So how can you relate that MDMA is related with this thing?
The thing is,
since it happened in mice, why you presume that it's happening in that particular person? Because already there's a add-on factor of diabetes is already there.
yes, the patient presented to us 20 days since his symptoms started. So we assume that we are already seeing it in a resolving stage. So the spike must have been 20 days prior.
Okay, but it's not a concluding thing still.
Yes,
So there is a lot of confounding factor. Anyway, we'll move on to the next. Thank you so much.
Thank you,
So we have Dr. Swati's slides. Yeah, so she's here for hyperbaric oxygen therapy for high altitude retinopathy. So the people traveling to Ladakh and higher altitude, please listen to this carefully. Yeah.
Good morning. I'll be speaking about a case of high altitude retinopathy managed with hyperbaric oxygen therapy. It's not moving. 25-year-old male presented to us with complaints of blackening of tips of fingers of his right hand and diminution of vision in his left eye of 1 week duration, which he noticed after summiting Mount Everest. The diminution of vision was insidious in onset, painless, and he described it as seeing a central black area obscuring his left field of vision. The clinical examination showed grade 4 frostbite in his right hand. The ocular examination in distant visual acuity unaided, right eye was 6/6, but left eye was 6/18 with no further improvement. The anterior segment examination was within normal limits. The fundus picture showed multiple hemorrhages in both eyes, and in the left eye there is a hemorrhage just at the fovea. The optical coherence tomography images showed hyperreflective areas with back shadowing suggestive of the hemorrhages. We kept the differential diagnosis of anemic retinopathy, B12 deficiency, sickle cell anemia, carbon monoxide poisoning, hypertensive or HIV retinopathy, leukemias, and central retinal vein occlusion. Considering his exposure to high altitude area and no clinical or lab findings other than frostbite, he was diagnosed as a case of high altitude retinopathy, both eyes. And for treatment, the patient underwent hyperbaric oxygen therapy, inhaling 100% oxygen by a mask at 2.5 absolute atmospheres in a multiplex chamber for 30 cycles. It was primarily for his frostbite. But in 1 week, we saw gross resolution of the hemorrhages with his visual acuity coming back to 6/9. And in 4 weeks, he had regained 6/6. High altitude retinopathy is known in people undergoing strenuous activities at heights of more than 4,000 meters, with lack of proper acclimatization being a known risk factor. The pathophysiology is hypobaric hypoxia and breakdown of blood retinal barrier. Severe HAR has associations with high altitude pulmonary edema and high altitude cerebral edema in up to 59% of the patients. The known complication in the visual field is up to 7 to 17% of the affected patients due to residual scotoma, visual field shrinkage, hemorrhage, subhyaloid hemorrhage, and BRBO. The role of hyperbaric oxygen is by increasing the dissolved plasma oxygen levels, and it enhances the tissue diffusion. So this is the first instance where we have found that the retinal hemorrhages have dissolved faster. These were my references. Thank you.
Very interesting topic, Dr. Swati. Where was this therapy given?
Sir, in Kolaba, Ashwini.
Where is it? In Kolkata only?
It's the Naval Hospital in Ashwini, sir. In Kolaba, sir, Mumbai.
Mumbai, okay, great. So the therapy was given by the medicine department or the...
We have a marine medicine department which has the hyperbaric oxygen chamber, sir.
Yeah.
And we cater for different diagnoses, including neural, like sensory neural hearing loss or lepra.
And where had the patient traveled? This patient?
1 week before he got to us, sir. Because he
Okay.
was sent from Delhi for his frostbite mainly. But instead.
Okay, because this treatment is not available easily. Very good, thank you.
Thank you, sir.
So now we have Dr. Mahalakshmi, and she will be talking on standout in rarity. Dr. Mahalakshmi, is she here? Okay, we don't have Dr. Mahalakshmi. So moving on to next, I'll call upon Dr. Pooja Sajjan, along with co-author Dr. Preeti Kapadia, for topic on occurrence of ROP in babies with low risk factors.
Good morning, everyone. I'll be talking about the occurrence of retinopathy of premature in babies with low risk factor. As we all know, retinopathy of prematurity is a disorder of development of retinal blood vessels in premature babies, which has become a major cause of preventable blindness in children. It is a vasoproliferative disease related to low birth weight, prematurity, oxygen administration, and various other factors. The WHO program of Vision 2020 targeted against the ROP, and it mentioned that the incidence of ROP can be decreased by early screening and timely referral for treatment. Although the ROP incidence and severity is higher in low birth weight and low gestational age, it is also seen in heavier and large babies in India, and they have consequently shorter window period for development of ROP and its aggressive form. Hence, we require early examination. The material and methodology, it was a cross-sectional hospital-based study done at a 50-bedded NICU of Tertiary Healthcare Center in South Gujarat. The study population included 131 infants and all preterm infants admitted in the NICU with gestational age of less than 37 weeks and birth weight of less than 2 kgs and chronological age of more than 14 days. All the neonates included in this study were divided into 3 groups based on their birth weight: extremely low birth weight, very low birth weight, and low birth weight, and were studied for the presence of exposure variables like chronological age, gestational age, multiple pregnancy, and so on. And the findings were documented in a semi-structured design like ROP zone, stage, and presence of plus disease. In the current study, there were 52% low birth weight babies, 37% with very low birth weight, and 11% with extremely low birth weight. And 93% of the babies having extremely low birth weight and very low birth weight had developed ROP. And it was found that and they had developed severe form of the disease. And it was found that the 32% of the babies with gestational age of 21% of the babies with gestational age of 32 to 34 developed ROP, and 32% of babies with 35 to 37 weeks developed ROP, and 2% of the babies with gestational age of 38 to 42 weeks. Prevalence of ROP in this study was found to be 80%, and 42% of the babies had zone 2 stage 1 and 15% had plus form disease. And the risk factors were low gestational age, low birth weight, presence of sepsis, respiratory distress syndrome, and so on. Here we can see that the birth weight, gestational age, and post-conceptional age and oxygen exposure had relation with ROP, and birth weight, gestational age, and oxygen exposure had relation with development of severe retinopathy. In conclusion, the current in present study, 131 of the babies were screened, and 80% of them had ROP, and 40% had zone 3 stage 1, and 15% had severe ROP. And the current study included preterm babies of less than 37 weeks gestational age and less than 2 kgs. It was observed that the 47% of the babies with ROP had gestational age of 32 weeks and more than 1.5 kgs. Therefore, the screening guidelines should be revised as per regional differences for the prevalence of the disease, so that we can screen more babies and diagnose ROP and prevent the blindness in children. Thank you.
What is the current guideline of RBSK for?
Sir, it says that the babies with less than 2 kgs and with NICU admission, oxygen exposure, sepsis, and any of the risk factors should be screened. And low birth
Gestational age?
Less than 35 weeks to
34 weeks.
34 weeks.
So you have already taken all the birth weights into consideration. So do you have a proportion which kind of babies developed what kind of ROP?
Yes.
It
Sir,
wasn't
the
there.
babies, the babies with low gestational had severe form, but it was found that in the babies with 2 kgs, more than 1.5 kgs, they had from the time of diagnosis to this progression of the ROP, they had a shorter window period.
So anyway, we have to follow the less than 2 kg criteria. So did you take kids who had more weight than 2 kg?
No, sir. If they did not have any
Ideally, the low risk factor would be considering the normal babies taking into for ROP screening and then realizing it. You have just increased the criteria of gestational age from 34 to 37, what I could understand in this. That was the only low risk thing you have taken. Beside that, anything else?
So, in our hospital, usually they screen from less than 1.5 kg, sir. Here we had screened 1.5.
Only weight is the criteria?
No, they consider gestational age, and if other risk factors are not present, but the baby had low birth weight of less than 1.5 kg, they are screened. But they did not consider the babies between 1.5 and 2 kgs weight, sir. So here we had screened for less than 2 kgs.
Okay. Thank you.
Thank you.
I'd like to call Dr. Thanusha for a top. Dr. Thanusha, is she here? Yeah.
Good morning all. Today I am going to present a case report of acute myeloid leukemia. Coming to introduction, AML is a malignant disorder of the hematopoietic stem cells characterized by abnormal proliferation of myeloid blast cells in the bone marrow and blood, preventing them further differentiating into specialized cells of the bone marrow and thus causing pancytopenia. AML can affect various tissues and organs like liver, skin and central nervous system, including eye and orbit. It occurs more commonly in adults than children and in men greater than women. Characteristic findings are presence of R rods, myeloperoxidase positive staining. Coming to case history, a 32-year-old male who came to ophthalmic OP with complaints of floaters in the right eye since 20 days, blurring of vision in both eyes since 10 days. On general physical examination, pallor with local rise of temperature was noted. So on ophthalmological examination, visual acuity unaided both eyes was 6.6 and anterior segment findings were normal. On fundoscopic examination, both eyes media was clear, optic disc was normal size, shape and color, margins were well delineated, CDR is 0.3:1. Background retina showed multiple deep and superficial pre-retinal hemorrhages. Rod spots are noted with macular sparing. Foveal reflex is present. B-scan ultrasonography was normal. So the patient was referred to physician regarding anemia and fever, where CBC was done. It showed severe anemia with severe thrombocytopenia. Peripheral smear showed normocytic normochromic RBC with anisocytosis, microcytes and teardrop cells. USG abdomen and pelvis showed mild hepatomegaly and moderate splenomegaly. 2D echo was normal. So patient underwent bone marrow aspiration and biopsy, which revealed acute leukemia. Acute leukemia comprehensive panel flow cytometry was done, and he was diagnosed as AML protein positive. Coming to treatment and follow-up, the patient was treated with 0.1% nebafenac eye drops. Patient has received chemotherapy. The patient was followed up for once a month for visual symptoms. After 3 months, the patient has decreased vision in the left eye, that is 636 with pinhole 624. Right eye was normal, 66. Anterior segment was normal. Fundus in right eye is normal. Left eye showed a lesion in the macular area. Foveal reflex was absent. So left eye OCT was done. It revealed an hyperreflective lesion over the macula. Coming to discussion, AML is ocular involvement ranges from 32 to 35.5%, which are as follows. The orbit chloromas, proptosis, swelling in area of temporal fossa. In conjunctiva, there may be repeated subconjunctival hemorrhages and severe dry eye. In cornea, there may be herpes zoster keratitis, leukemic hyphema or pseudohypoma. In lens, there may be occurrence of cataract. In iris, there may be heterochromia and obliteration of the iris crypts. Coming to conclusion, ophthalmic involvement may be the initial manifestation of the systemic disease or the first sign of relapse. So examination of the patient as a whole and prompt referral follow-up may help in the early diagnosis and improve the quality of life of patient. Thank you.
Thank you, doctor. What were the typical hemorrhages in the retina? And what do you think was in the left eye at the end of your treatment?
Yeah, I think it may be the resolving hemorrhage.
Yeah, it's kind of a dehemoglobinized blood. Yeah. And what are the typical hemorrhages you see in such cases?
Pre-retinal hemorrhages.
Yeah, but that can also be seen in other conditions like Terson and all those things. Anyway, these are the cases which we need to see constantly because they are rare in our OPD, and then we need to make a diagnosis that it is related with AML. The things which you have mentioned, the chloromas, the conjunctiva, and also if you see anything atypical, you see a lot of papillae and the conjunctiva doesn't seem to be normal. Don't consider it as just as a conjunctivitis or an allergic. Just go ahead and ask your colleague that what you think could be the other reason behind it, because these are frequently missed cases when we seen in OPD. Anyways, thank you so much. I'd like to call upon Dr. Prabhuvan Raja for his scleral melting porphyria. So these are few of the rare conditions which we are discussing here. Over to you, doctor.
So good morning, everyone. So I am gonna present about scleral melting porphyria. So porphyria is derived from a Greek word. Porphyrus means purple. So it's a group of metabolic disorders. It is due to abnormal functioning of the enzymes in the biosynthesis of heme, so which results in excessive accumulation of porphyrins and their precursors. So it's of 8 types, and eye involvement in porphyria it's rare, and it can manifest as lead scarring, ectropia, pedunculate pterygium, and acute scleritis with scleral necrosis, corneal thinning, and corneal perforation. So the mechanism is the porphyrin, which are precursors, they are present in the tears. When they are exposed to the sunlight, they initiate activation of inflammatory responses, which can manifest as acute scleritis with scleral necrosis or corneal thinning and corneal perforation in the interpalpable areas. So it is because of the interpalpable areas because of the phototic damage. So the case is about a 40-year-old gentleman. Is a school teacher from Jharkhand. So he is diagnosed of congenital erythropoietic porphyria in 2018. He has skin lesions, blisters in the exposed areas since 6 months of age, and complaints of red colored urine, and his younger brother died due to the similar illness. So at presentation, he complains of inability to open the mouth and irritation and redness in both eyes and skin lesions all over the body, and even absence of nose and loss of fingers and toes. On general examination, he had hyperpigmentation and lichenification of skin over exposed areas and resorption of fingerstill PIP joints in hands and feet, and face showed diffuse lichenification, pigmentation, and in forehead he had waxy and lichenified papules, and nasal bone was fully eroded up to the glabella, and he had restricted mouth opening. On eye examination, he had a BCV of 6/6, and his cornea was clear, and IOP was 16 mm mercury, and fundus of the normal mids. But in the but he showed scleral thinning and angular bufferon. So investigation of urine porphyrin is found to be positive, and the CRP is 4.36, and gastroscopy is called esophageal varices, and skin biopsy from 4 source suggestive porphyria, and even genetic tests showed uros exon 10 heterozygous. So the mutation in the uros in this gene, it can reduce the uros enzyme activity, which can increase the porphyrin, which on reaction to light can increase the inflammatory response and cause damage erythrocyte also. So it is according to depends on the level of residual uros activity. So it can disease severity can range from non-immune hydrospitalis to late onset disease with mild to mild cutaneous involvement. So clinical diagnosis on exposure to light, patient can have bullous vesicular lesions, and can have even erythrodontia as it's a bone discoloration of teeth. So management mostly results in strict avoidance of exposure to visible light, and adequate care of the ruptured blisters, and symptomatic hemolytic anemia therapy and therapeutic approaches. So mechanism of for ocular management, mostly on the early stage we can treat with copious lubricant use, general protective measures, and vitamin A can be used topically and systematically. And for scleral patch graft can be used to restore the globe integrity, and if it's cornea involvement, Boston keratosis can be used. So prompt diagnosis, appropriate management, and photoprotection can prevent the progression to globe threatening conditions.
Dr. Prabhuvan, do you have any take-home message where we can diagnose porphyria in OPD just by looking? Because scleral melt can occur through various causes of scleritis also. So any take-home message for all of us?
So the main thing is on exposure to sunlight, the scleritis can increase.
The scleritis can increase.
Yes.
That is one of the things. So that will probably make us think in that way of porphyria. So another interesting case. Thank you so much, Dr. Prabhuvan. It must be very difficult diagnosis if we had come to an eye OPD and then we have to find it out. Anyways, very good. Moving on to our next speaker, Dr. Charisma Samuel. She'll be talking on a case of mistaken identity. You are Dr. Charisma, right? There's no mistaken identity. Okay, please carry on.
I'll be talking on a case of mistaken identity on ocular syphilis. Syphilis is caused by treponema pallidum. It penetrates the intact mucous membranes or abraded skin. The period of incubation is 3 to 90 days. It's a great imitator, so it presents in different, it has different presentations. Syphilis in India, seroprevalence is around 0.79%, and the people at the highest risk are men who have sex with men and with HIV infection. The ocular manifestations are 0.6 to 2%, and it can have a myriad of presentations like scleritis, keratitis, anterior uveitis, intermediate uveitis, retinitis, chorioretinitis, choroiditis, neuroretinitis. This is a case report of a 28-year-old unmarried male. He's a fashion designer hailing from Odisha. He's come with initial complaints were persistent progressive erythematous scaly lesions on the face over duration of 6 months. He was diagnosed as palmoplantar psoriasis, and he was treated with acitretin and topical steroids, but they showed no significant improvement. 3 months later, he came with complaints of acute onset painless decrease in vision in the left eye, and he was diagnosed as optic neuritis from a local hospital, and he was treated with IV methylprednisolone as 3 doses, but he showed no improvement, and he also had associated transient neurological symptoms like hemicranial headache, imbalance while walking, and tremors and paresthesias. On initial examination, right eye was within normal limits. Left eye had vision of 618 and 10 with few cells in the AC with RAPD and presence of vitritis, disc edema, and inferior nasal area of vasculitis and a chorioretinitis patch inferiorly. The WBC count was showing 5,700. This is a fundus photograph of a large retinitis patch inferiorly in the left eye, which was confirmed with an FA. On follow-up, the right eye also started developing an anterior uveitis with inferotemporal chorioretinitis patch, and the left eye also the vision dropped 660 N12 with anterior uveitis and a hypopyon, dense vitritis with disc edema and more extensive vasculitis and chorioretinitis involving half of the retina. The investigations were showing serum RPR reactive, serum TPHA reactive. HIV was also present with a reactive with a CD4 count of 199. CSF analysis showed signs of aseptic meningitis with RPR and TPHA reactive in the CSF. We started topical steroids, Q1 Ali and cycloplegics 3 times a day in both eyes, and we started the injection crystalline penicillin 4 million units Q4 Ali for 7 days, followed by ceftriaxone for 7 days and prednisolone 50 mg OD. At discharge, the visual acuity in both eyes was 6.6 and 6 with grade 1 RAPD in the left eye. Anterior segment showed no inflammation with posterior segment also with mild disc pallor. The left eye patient was sent, conclusion, the highly level of suspicion is required for early diagnosis due to syphilitic etiology, and management of syphilis requires a multi-speciality team effort. And thank you.
Yeah, thank you. A very nice presentation, Dr. Karina. The thing you never miss a cells in your OPD. Even if you see any case of redness, make sure the interior, before writing, the interior chamber is really quiet and not just like that you write it. Because a small thing can make you lead to the vitreous and then the placoid retinitis in case of syphilis also. So make sure before writing, either you don't write it, and if you're writing, make sure you don't see any of the cells. So that is the one thing for any of kind of uveitis workup for the future. Thank you, Dr. Karina. Over to Dr. Vijaya Saharaja. She will be talking on diabetic papillopathy in patients with type 2 diabetes mellitus.
Good morning to everyone. Today I'll be talking on a case of diabetic papillopathy in type 2 diabetes mellitus. Diabetic papillopathy is a rare cause of optic disc edema seen in 1.4% of type 1 or type 2 diabetic patients regardless of metabolic control or severity of diabetic retinopathy. It is often missed and misdiagnosed because patients have minimal to no visual symptoms and there is no optic disc dysfunction. Characteristic hyperemic optic disc swelling and telangiectatic vessels in and around the disc can be seen with or without macular edema. 44-year-old male presented with sudden onset painless progressive worsening of defective vision of both eyes over the past 2 months. He is diabetic and hypertensive under medications. General survey and systemic examination were within normal limits. On ocular examination, his best corrected visual acuity on right eye was 6/36, in left eye 6/60. Anterior segment examination was within normal except for a nuclear sclerosis grade 2 cataract in both eyes. On slit lamp examination on the right eye, the media was clear. The disc margins were blurred inferiorly with a vertical cup disc ratio of 0.3. Vessels were tortuous along the inferior arcades, and succinate patterns of hard exudates with dot and blot hemorrhages were seen. In the left eye, disc appeared hyperemic with a blurred margin circumferentially with poorly demarcated cup. There were tortuous vessels along the superior and inferior arcades, and hard exudates and dot and blot hemorrhages were seen, along with cottonwool spots along the inferior arcades. There is no NVD or NVA. Lab investigations revealed a deranged HbA1c of 8.9. Rest were normal. Optical coherence tomography of the right eye showed diabetic macular edema with a central macular thickness of 714 micrometer. In the left eye, the CMT was 319 micrometer with intraretinal fluid. The Humphrey visual fields revealed enlarged blind spot in the left eye. Neuroimaging was within normal. The patient was given intravenous high-dose methylprednisolone for 3 days, followed by oral methylprednisolone. Patient was reviewed on day 14, and his best corrected visual acuity was right eye 6/18 and left eye 6/12. Coming to the discussion, literature suggests that disc edema is caused by superficial retinal vascular disturbance with transient leakage of fluid into and around the optic nerve head. Since diabetic papillopathy is a diagnosis of exclusion, it is critical to rule out other possible causes such as AION, optic neuritis, and other causes of increased intracranial pressure. So far, no clear recommendations have been established regarding its management. Periocular corticosteroids and anti-VEGF have been tried successfully in few cases. So I'd like to conclude by saying that as diabetes is highly prevalent, it is imperative for eye care providers to be familiar with some of the less common ocular complications of diabetes, including diabetic papillopathy, and pharmacological treatment can be managed on an individual basis with coordination between neurologists and ophthalmologists with close monitoring and follow-up. These are my references. Thank you.
Thank you, Dr. Vijaya. Did you do an FFA in this case?
No, sir.
Okay. FFA helps to aid the diagnosis of optic papillopathy, optic disc papillopathy in diabetes, and
No, sir.
you started on IVMP. I hope it was under management of some physician because it
Yes,
shoots
sir.
up.
Yes, sir.
The treatment for optic neuritis would have been the same again.
Yes, sir.
So MRI was clean.
Yes, sir.
MR angio, you did MR angio?
No, sir. MRI was done. It was clean. And since we had a difference of opinion that whether it was an early AION which was progressing or diabetic papillopathy, so to conserve the vision, we started on IV methylprednisolone.
That's okay, but you know steroids shoot up the diabetic
Yes,
part.
sir. It was under the physician management. The patient was admitted to our hospital, and then treatment was initiated.
Ask history of pain also, optic neuritis.
It was
yeah.
absent, sir.
All right,
Rest all
thank you.
features were normal.
Over to Dr. Abhishek for efficacy between PST versus anti-VEGF in macular edema.
Hello, my topic is to compare the efficacy and safety of posterior subtenon steroid versus intravitreal anti-VEGF Avastin in diabetic macular edema. Diabetic macular edema is manifested in retinal thickening caused by accumulation of intraretinal fluid in the inner and the outer plexiform layer due to hyperpermeability of retinal vasculature. As in the picture, we can see the swollen macula and leaking blood vessels. Two main mechanisms which lead to DME are elevated VEGF expression, which is basically the vascular model, and the inflammatory model. The vascular model states that due to retinal vasculature changes and retinal ischemia causes increased VEGF expression, causing inflammation and macular edema. And the inflammatory model states that inflammation causes direct neurodegeneration as well as it causes the expression of VEGF, causing vascular changes and diabetic macular edema again. Here is the inflammatory model explained again. There are various pro-inflammatory agents which are ICAM, VCAM, integrins, interleukin 6, interleukin 12, etc., causing activation of microglia, Mueller cells, astrocytes, causing low-grade inflammation, cell apoptosis, and retinal ischemia. Coming to a first drug, the anti-VEGF Avastin, bevacizumab, it is FDA approved and used in the treatment of advanced solid cancer. Though it is widely used off-label, it is widely used off-label in the treatment of diabetic macular edema and worldwide. It includes antibody to VEGF and other fusion protein binding to all isoforms of VEGF-A. Fusion proteins bind to VEGF-B and placental growth factor as well. Coming to a second class of drugs, steroids, glucocorticoids signal through the genomic and non-genomic pathways. Most of the anti-inflammatory effects of steroids appear due to important negative regulatory factors called trans-repression, which is repression of transcription, binding to nuclear factor kappa B, which is a major pro-inflammatory gene causing expression of many inflammasomes. Our second drug, triamcinolone acetate, acts on multiple levels to control disease progression, reducing inflammation, tissue injury, reducing VEGF. 49 eyes were studies, 26 were given 1.25 ml, 0.05 intravitreal bevacizumab, and 23 were given low dose 4 mg, 0.1 milliliter of PSTA. IC approval taken, inclusion criteria 500 to 600. Main endpoints were BCVA, CMT, and IOP after 1, 3, and 6 months of studies. Now coming to the results, BCVA improved improved 70%, while in PSTA 47% only. Mean CMT improved 532 357 after 6 months, while in a PSTA 567 to 408. It was not different in 6 months. Recurrence of macular edema was not different in both the groups as well. Intraocular pressure elevation was noticed in 1 and 3 months in the PSTA group, which was medically managed by topical AGMs, but IOP declined by the end of 7 months. Conclusion, intravitreal Avastin achieved better BCVA. CMT was comparable. PSTA transient elevation at 1 and 6 months, which declined to baseline by 6 months. Clinical implication was intravitreal anti-VEGF expensive, off-label, multiple doses in single vials, requires vitreoretinal surgeon, complications such as retinal endophthalmitis, retinal detachment, etc. Hence, PSTA can be used in government colleges without VR, rural setups, and non-affording patient as a first line in diabetic macular edema. These are my references. Thank you.
Thank you, Dr. Abhishek. We are running out of time, so please stick to the timing. So I'd like to invite Dr. Rupa, and it would have been better if Dr. Abhishek and Dr. Rupa had combined their topics and presented it, because Dr. Rupa will be presenting on IVTA in DME, so it would have been a complete topic. Over to you. Slides, please.
Thank Thank you. Good morning, everybody. My presentation is on study of CFT, central foveal thickness, and its correlation with visual acuity after IVT injection 4 mg in diabetic macular edema. As we all know, central involved diabetic macular edema is the most common cause of visual impairment among working class population among diabetics. Among the armamentarium, various armamentarium, corticosteroids plays an eminent role, especially in middle and low income countries, because of cost involved in anti-VEGF and hence the need for the study. This study undertook at hospital-based prospective interventional study for a duration of 18 months where 30 diabetic macular edema treatment-naive patients underwent IVT injections. So methodology involved basic demographics and visual acuity, which was recorded with Snellens and later converted to logMAR, anterior segment, and OCT was done using top-1 OCT, where macular radial scan protocol was used. After IVTA, patients were followed up for first day, first week, first month, and 3 months thereafter, and each monitoring was done by visual acuity and macular OCT. These are the serial OCT photographs which shows pre-injection first month and 3 months, where the macular edema resolved promptly at the end of 3 months. These are the basic demographics of our 30 patients. And this line chart shows a BCVA. There is a statistical significant difference between pre-injection and first day, first week, first month, and third month. This, when we compared it to Hassan Ahmed et al. Study, where the BCVA at the end was 0.33, ours was 0.47. So we analyzed it because our study had a worse baseline visual acuity than them, and hence the improvement of visual acuity was also lesser than them. CFT, our study showed a reduction of 34% after 1 month, and which further reduced at 3 months post-op 44% of the baseline CFT, which was statistically significant and agreed very well with Martinez, Mansoor, and Masson et al. Study. The Pearson's correlation between BCVA and CFT pre-injection, first month and third month had a positive, but they were not statistically significant in our study when compared to Atwa and Shimura et al., which showed statistically significant. Our limitation being a non-comparative small size and short follow-up study, we concluded our study efficacy of a single dose of 4 mg IVT in reducing CMT and improving visual acuity, at least in the short term. Thank you.
Thank you, Dr. Rupa. So you have to, I'll call up the next speaker, Dr. Kiri Adikumar, for her frosted branch uveitis in SLE. So thank you, Dr. Rupa. It was a nice presentation. The thing is, we have to figure out the cases where we are planning to put up the steroids and where we are planning to take up the anti-VEGF. So it's more of a, on the vascular side, hemorrhagic side, you tend to go for a anti-VEGFs, and if it's a CSME, you tend to go for steroids in most of the cases. So you can further go on with your studies with Ozurdex also, with the intravitreal.
From a basic district hospital setup.
Okay. Maybe in the future you have an IVTA starting, then you can plan up with a comparison between Ozurdex, how it has affected the first month or not. And is moving on to our next speaker, Dr. Kiri. Okay, she's absent. So we have Dr. Tripti.
Hello. My presentation is on correlation of hypertensive retinopathy with cardiovascular disease. It's not moving. Hypertension is a worldwide problem. Hypertension doubles the risk of cardiovascular disease, and since retina provides a window to study the human circulation, we conducted this study. There were 60 patients. The inclusion criteria was systemic hypertension of any duration. Exclusion criteria: diabetes, kidney disease, and failure to give consent. A complete ophthalmic examination was done, including BP dilated evaluation. We used Keith and Wegener-Baker classification for grading the retinopathy, and the systemic investigations that were done was CBC with ESR, platelet count, RBS, electrolytes. To check for the cardiac we incorporated doing ECG and echo. So our results, majority were males and females were around 17%. So among the patients which we screened, the majority which we found was in stage 1 of hypertensive retinopathy, and The results, ECG changes in hypertensive retinopathy which we saw was left ventricular hypertrophy, sinus bradycardia, T-wave inversion, incomplete LVB with premature contraction, mild LVD. Which we observed was that the abnormal ECG changes were more in grade 4 compared to grade 1 hypertensive. And the abnormal echo changes which we found was concentric left ventricular hypertrophy, pericardial effusion, sclerotic aortic valve, and diastolic dysfunction. There was asymmetrical septal hypertrophy and cardiomyopathy, global hypokinesia, left ventricular dysfunction with low ejection fraction. So we saw that the abnormal echo changes were almost all the patients who had abnormal echo had grade 4 hypertensive retinopathy. They were less in grade 1. So the discussion is that hypertensive retinopathy was prevalent, 40 to 60 years of males being more affected. It's similar to a study done in Delhi. Retinal complications that were seen were macular edema, optic disc involvement, branch vein occlusion. Bullous retinal detachment was seen in one patient. Macular edema, optic disc atrophy, and retinal detachment was seen in all grade 4 hypertensive retinopathy. Hypertensive retinopathy results from the arterial damage due to elevated blood pressure. Microvascular damage in retinal arterioles may be associated with concurrent microvascular changes in coronary circulation. So there was a moderately significant association between hypertensive retinopathy and concurrent cardiac changes as evidenced by echo. So we might benefit from like screening all the patients for hypertensive retinopathy, especially in post-COVID era where all these coagulopathies have shot up like anything. Thank you.
Very interesting talk, Dr. Tripti. Thank you so much. So in our OPD, if you see a hypertensive, get a cardio workup also. And now we have Dr. Ravish Bindal. He'll be talking on marvelous effect of IVMP in a case scenario. Sorry, is it CRAO? Okay, in a case of CRAO. So CRO being treated with IVMP, is it?
Sir.
Okay.
Good morning, respected chair and all present. So today I'm going to present a case report of a patient who presented to our OPD with diminution of vision in one eye for just one day. The best corrected visual acuity in the patient in the affected eye was finger counting close to face with PR accurate. The other eye was absolutely normal. The anterior segment examination, the positive findings was that RAPD was present in the patient's affected eye with the fundus examination showing a cherry red spot. The OCT was suggestive of thickening and hyperreflectivity of the inner layers, as I would present in the next slide. Probable diagnosis of CRAO was made. Urgent AC paracentesis along with ocular massage and other therapies, carbogen therapy was given to the patient, and patient was started on after the physician clearance, other full body examination, other systemic workup, the patient was started on intravenous methylprednisolone next day onwards for 5 days. This is the fundus photograph of the patient on the day of presentation along with the OCT of the right eye. So the patient was an OPD patient, and the results, the patient's vision started improving gradually. The patient was followed up on regular intervals weekly for about 2 weeks, followed by monthly intervals for about 3 months. After a span of 6 weeks, 6 weeks of treatment, the right eye's visual acuity improved on, if you could remember, the day of presentation, it was finger counting. On the 6th week, it was 6/9, 0.2 logmar. This is the fundus photo at 6 weeks, along with the OCT photo of the right eye. So to discuss further, CRO refers to an abrupt diminution of blood flow through the central retinal artery, which is severe enough to cause ischemia of the inner retinal layers. And it's an ophthalmic emergency, and prompt and urgent management is must for this case. There are a number of therapies that have been advised for CRAO, including carbogen therapy, acetazolamide, and ocular massage, etc. As stated in case reports by Matskin and Kogati et al., systemic steroids have shown to improve visual acuity. In their case report in 1991, Husman and Richard also stated beneficial effects for the same. On the other hand, we don't, Clarkin et al. And talk about that visual recovery in 2 patients after intravenous methylprednisolone treatment of CRAO secondary to giant cell retinitis was also noted. Pandit et al. Counter the claim of Hausman and Richard and advocate that IV steroids should not be used for restoration of visual function as they are less efficacious and have high risk factor profile. So to conclude, intravenous steroids have shown promising effects in the restoration of visual recovery in case of CRAO, but further research is required. Thank you.
Thank you, Dr. Ravish. Meanwhile, I'll call up Dr. Kusum on the stage while we discuss this topic of Dr. Ravish. Dr. Ravish, you can take the chair. The only thing is, this is not a take-home message. Definitely, in a CRAO, you are not putting up IV MP for any reasons. What is the logic behind it?
So literature has shown that especially for the arthritic case, which are primarily associated with vasculitis.
That is inflammatory cause is one of the reasons for that.
So that is why that we suggest that yes, we have found this, and after the presentation putting this paper, we found 2 more cases in which in one case we have the patient presented with hand movement on POD 2. So POD, I'm saying the presentation, he had diminished vision for about 2 days, and after the therapy, patient's vision improved to 6/12.
Okay, Dr. Ravish, I won't like to interrupt you in between,
sir,
but just that there are isolated cases which have been treated in and out of some or the other therapies, but till you have a documented FFA diagnosing it as a complete CRAO case, don't go for it, because when the first picture and the second picture you showed appeared more or less same to me, plus there was a temporal disc pallor also in both the photographs, so I won't take it as a diagnosis of CRAO on face till I have the proper investigations with me.
Thank you so much, sir.
Yeah. Paracentesis again, that might have worked in a later stage, but they are definitely, and the patient was also on anti-glaucoma with that. So I think paracentesis does the magic in many of the cases. So yes, thank you.
Thank you so much, sir. Thank you.
Over to Dr. Kusum. I don't have a topic. Yeah.
Good morning, everybody. The topic is a case study on Coats disease and its management with intravitreal ranibizumab.
Ma'am, use mic, please.
Coats disease is an idiopathic condition characterized by retinal telangiectasia, aneurysms, and exudation. George Coates first described it in 1908 as an unilateral condition with retinal exudation and telangiectasia in male children. My aims and objectives are to describe the clinical features, treatment, and outcome of Coats disease, to review the typical imaging findings along with its clinical presentation, to find out efficacy of intravitreal ranibizumab in treatment of Coats disease. Mine was a case study of a 6-year-old boy who presented in the OPD with dimness of vision, gross dimness of vision in the left eye. A detailed history and complete ophthalmologic examination was done. Visual acuity was 6/9 in the right eye and 1/60 in left eye. The NCT was 13 mm in right eye and 14 mm in left eye. Slit lamp showed yellowish leukocoria in the left eye. Examination under anesthesia, FFA, MRI, brain and orbit, USG, B-scan, OCT, all were done accordingly. You can see the leukocoria in the left eye. Now, examination under anesthesia showed subretinal and intraretinal exudation in macular region. FFA revealed abnormal inferotemporal vessels with telangiectasia with leakage from abnormal vessels. USG B-scan showed calcified foci posteriorly. MRI was nothing significant. OCT revealed foveal thinning with CME in the left eye, and the patient was diagnosed as Coats disease. Now, the intravitreal ranibizumab was given in left eye, and vision improved from 2/60 to 6/60 initially, and later it turned out to be 6/36. This is the fundus photograph. You can see the telangiectasia and the exudation, and the fundus fluorescent angiography showed leakage from the abnormal vessels. The MRI report was nothing significant, and we can see the OCT. It's the macular edema. So, Coats disease is an idiopathic exudative retinopathy with abnormal telangiectasia, edema, and lipid exudates in the retina in young males. So, after injection of ranibizumab in the left eye, the BCVA improved from 2 by 60 to 6 by 36. So, thus intravitreal anti-VEGF helps in reduction of vascular permeability and edema, which augment laser photocoagulation effectiveness. So, it is a promising new addition. This intravitreal anti-VEGFs are a promising new addition in our pediatric retinal tool. With reduction of vascular permeability, there is reduction in subretinal lipid exudation and macular edema. So, Coats disease advocate for comprehensive eye examination along with pupillary dilatation early in life for correct diagnosis, so that timely intervention with anti-VEGFs and laser and other modalities can help us to reach a favorable ocular and visual outcome. That's all.
Thank you, Dr. Kusum. So for course, we have the laser and the injection. So injection will help with the lasers. So basically do an FFA, get a laser done, and then addition of anti-VEGFs as per your study. Thank you, everyone. I hope you had some insight on different topics which have been going in our country. So thank you, everyone, for attending.